This episode, I'm chatting to Dr Gavin Wheaton. Dr Wheaton is a paediatric cardiologist at Adelaide's Women's and Children's Hospital and a part of the Deadly Heart Track. Deadly Heart Track is a group of experienced doctors and local healthcare workers and Aboriginal leaders visiting communities across Australia to diagnose, treat and help prevent RHD, all while learning and responding to the needs of the communities.
It's possible to make an early diagnosis, treat with penicillin, prevent those future episodes of those recurrent episodes of rheumatic fever and end up with good heart valves. So that's the purpose really in what we're doing with screening.
Before we begin, we'd like to acknowledge that we're recording on the traditional country of the Kaurna people of the Adelaide Plains. We pay respects to elders past, present and emerging. We pass that respect to any Aboriginal or Torres Strait Islander listeners. So a very warm welcome to Dr Gavin Wheaton. Gavin, can I call you Gavin?
Of course you can call me Gavin. Thank you, Sami. It's a pleasure to be here.
It's really nice to have you in studio with me tonight. It's usually beamed across different cities across Australia, so it's lovely to have us both in the studio in Adelaide. So, Gavin, tonight we'll be talking a lot about rheumatic heart disease. So most listeners of the podcast are very familiar with CHD, congenital heart disease, familiar with defects, but I suppose it'd be really great if you could explain to us about what is RHD.
So rheumatic heart disease, which follows an illness called rheumatic fever or acute rheumatic fever, is an acquired form of heart disease as against congenital heart disease, which you mentioned earlier. And globally, it remains an extremely important cause of heart disease in young people. So just to explain briefly how this occurs, rheumatic fever usually follows a throat or skin infection with the streptococcus bug or strep, and that sets up an immune reaction or immune response that causes inflammation of heart valves, and that is known as carditis. And the illness consists of a number of key features. So there is usually fever. Very often there is arthritis, which may affect multiple joints. There can be abnormal movements, which are called chorea, and the carditis. And so those are the key features. There can be a rash as well. And so that's the acute phase of the illness. All of that will settle down with the exception of the heart valve problem, which may then become chronic. And so that damage to heart valves that comes from the inflammation of rheumatic fever leads to what we call rheumatic heart disease.
Okay, that's a really thorough explanation. So for people listening, how long is this onset? So obviously we're all familiar with getting a sore throat or getting tonsillitis or something. Is strep throat similar to that? And how long between having strep throat before we see the effects of the damage to the heart valves?
So typically it's a couple of weeks between the skin or throat infection and the illness of acute rheumatic fever. So there is a window of opportunity there to treat the streptococcus and to prevent rheumatic fever from occurring. But it's also important to understand that very often there isn't an obvious history of a preceding illness. So a history of strep throat is actually relatively uncommon in Aboriginal kids and adolescents.
Okay, and so you just touched on Aboriginal kids. So you said that this is obviously RHD, we see it across the world. So in Australia, where do we see it most? Is it mainly in our Aboriginal community?
Very much so. And so this is an illness that has largely disappeared in the white population in Australia. 100 years ago, there was similar incidence in the community to what there is in Aboriginal people today. But unfortunately, in the Aboriginal population, it persists at very high levels. And in fact, we have one of the highest incidences of rheumatic fever and rheumatic heart disease in the world.
Wow, that's really quite confronting to hear that we're one of the highest in the world. And I'm sure people listening across Australia, some may be aware of this. We've shared other podcasts about people who've shared their stories of having RHD and needing to go for valve replacements. So when you say it's been eradicated, if that is the correct word, from the majority of the white population, why is it still so prevalent in our Aboriginal communities?
So this is a disease of disadvantage. And so when you look across all populations, a proportion of the population will be prone to getting rheumatic fever, but it requires the social determinants as well as that predisposition. And by that, I mean poor housing, nutrition, overcrowding, a high burden of infectious diseases, poor hygiene generally. So these are all markers of disadvantage, and they are necessary for rheumatic fever to occur. We know that if you address those social and economic determinants of health, rheumatic fever goes away. And that has been shown repeatedly in populations around the world. So that largely it is still prevalent in developing countries, but is also prevalent in a small number of affluent countries, notably Australia and New Zealand.
It's all very confronting to hear what you're sharing with us, in the respect that due to socio-economic reasons, obviously I know you've referred to overcrowding, obviously hygiene and all those other factors that are playing, but then you just referred to us as Australia as an affluent country, yet we have the highest in the world. It's quite confronting to hear. But that's obviously why we've got you here tonight, to share more and have a better understanding of what we can actually do about it, but also to the solutions that we can provide. So obviously, if we can lead into, now we understand what RHD is, if we can talk about the work that you're doing with the Deadly Heart Track, and I know this is not just yourself, there's other people involved. Can you tell us about who they are?
The idea of the Deadly Heart Track really came from my friend and colleague, Dr Bo Ramini, who is a paediatric cardiologist based in Darwin. And Bo has worked there for about 10 years and has had long experience of rheumatic heart disease and has done a lot of work in this area, and in fact was the Northern Territorian of the Year several years ago for that work. Bo had the seeds of an idea to do a trek across Australia, and this is based on the fact that when you look at where rheumatic fever occurs, it's particularly in the north and the centre of the country, and particularly in remote communities. Those remote communities receive very little in the way of visiting services, and access to services, as we understand it in the cities, is more difficult. I think there's no question of that. And so part of the idea of this trek across Australia was to take expertise and services to remote communities and to work with local health staff, with community, with families, and in the schools. I think the other thing to understand about this concept is that we have done a lot of work, and there's been a lot of work worldwide, in fact, on screening for rheumatic heart disease using ultrasound or echocardiography. And just over 10 years ago, criteria for the echo diagnosis of rheumatic fever were published in Nature under the auspices of the World Heart Federation. And those guidelines have been used in most of the screening work that has been done since in many locations around the world, largely in research projects. So there has been quite a lot of information coming through about screening, and we've certainly been involved in this country and have developed a lot of expertise in the use of echo for screening for this disease. And just to explain briefly what that means, so we use ultrasound with a very brief screening protocol where we focus on the two heart valves that are usually affected, or most often affected, by rheumatic fever. So that's the mitral and the aortic valve on the left side of the heart. And we can do a screening echocardiogram in about 2 minutes.
Wow.
And reliably diagnose rheumatic heart disease.
So, Gavin, you've just shared that obviously with your great colleague, probably dear friend now, with the work that you're doing, Dr Bo up in the Northern Territory, you said the seed of the idea came about of obviously doing this trek, and she's obviously reached out to yourself and other people. Has this come about because you were seeing more cases? Were you seeing more cases actually come into, like you're saying, we're talking about these remote areas where there is minimal medical services or general services? Did that come about because, hang on a minute, we're seeing more patients coming through, or was it more alarming the fact that as time was going on that these weren't declining and it's mostly eradicated?
We have been seeing more cases, sadly, and the national data confirms that. So the Australian Institute of Health and Welfare publish a regular report. The most recent report covers the period 2017 to the end of 2021, and it does show an increase in rheumatic fever cases during that period, a significant increase, in fact, from just over 500 cases in 2017 to over 600 in 2021.
Yeah, okay. So well over 10% increase.
Yeah, and along with that, numerous new cases of rheumatic heart disease as well. We've also been very concerned during COVID that services were really struggling, that there were problems particularly in remote communities with staffing clinics, with providing just the basic day-to-day services. So I think that's probably part of what we've seen, but we've certainly been very concerned about both the number of cases presenting and also the severity of disease that we've been seeing.
So there's a group of you, there's obviously yourself and Dr Bo, and there's a group of you that obviously are a part of this trek. So could you help us understand the trek? So because you've just obviously explained that realistically in layman's terms, the diagnosis is pretty quick and pretty, like, it's not invasive, isn't it? You're talking about an echo. The community that is listening to us on this podcast, we're all familiar with ECGs, echoes, all those general sort of appointments. So to think that there's a group of you going into these remote communities and I'm assuming with fairly simple equipment and diagnosing quite quickly. So what's the response like within the community when you go in?
Well, the response has been tremendous, actually. Just to backpedal a little bit, the original idea was that we would do this as a single continuous trek, but COVID obviously got in the way of that.
Yeah,
and
COVID got in the way
of a lot of things.
A lot of things, yes.
And so we have been doing the trek in instalments, if you like. We have visited top-end communities. We've visited far north Queensland and most recently Central Australia. We go where we're invited, of course, but the great majority of communities have been very keen for us to come. And having visited, the level of engagement has been tremendous, actually. We've been really well received, and that's across the board, health staff, community, families, and particularly the schools and the principals have been fantastic. Because, of course, we do the screening part of this work in the schools, and we screen school-aged children.
Thank you. Thank you I was just about to ask around the school side of things, because I suppose we're talking about providing a medical service and diagnosis, and so the thinking is this is going to look like a clinic. And I was going to ask you, what does this look like? So I'm picturing a school setting as in a classroom. Obviously you plan in advance, you've been invited. What does it look like actually when you go in? Are you in for a day, 2 days, weeks?
We would usually spend no more than 1 day in a school. Often we're moving between schools, between communities. What does it look like? A little hard to describe, but I guess in short, we have people receiving the kids. The teachers, incidentally, as I mentioned previously, have been fantastic and they help enormously with moving kids through the room. But we have part of the team receiving the kids. They will then do a reasonably structured education session with the kids and show them a couple of videos and make it fun as well. Then the kids will be brought through to one of the screening stations where either cardiologist or a cardiac sonographer will do an expert screening scan. For the kids who are positive and need to have treatment, and where discussion with families, education and arrangements for follow-up need to be made, we will do that wherever possible on the spot. And that's generally been a successful model, not always. Sometimes we've needed the assistance of the local clinics to follow up with families and ensure that the treatment and the follow-up is occurring.
So, Gavin, if I can take you back to what we were just chatting about from the get-go. So it starts with an infection. So you get an infection, obviously what we would see in the local community, if I was to present or one of my children were to present, they'd be prescribed an antibiotic.
Yes.
So these children are getting an infection, the antibiotic, because of the lack of services and that whole socio-economic reason, and obviously being remote, that's not happening. Then the group of you are going in, and then you're going in, you're not just going in, you're getting invited into these communities, you're setting up makeshift education, follow-up, diagnosis. How many are you diagnosing when you're going in? And this must be incredibly frustrating for you to see as a medical professional, to think that if we stepped right back, this was a script of antibiotics.
Look, it is extremely frustrating and disappointing. I first went to Central Australia 40 years ago. My first case of rheumatic fever during that time, I don't believe that, I think an enormous amount of very good work has been done by a lot of very good people in the intervening period, but this disease has not gone away. It's not better, it's worse.
It's worse, yeah.
One thing I would just mention is the importance of skin in this.
Okay.
So as I said earlier, I think we don't often get a history or a presentation with sore throat preceding the rheumatic fever.
Okay.
Skin infections are extremely common.
Okay.
Particularly in these remote communities. And so that's in particular school sores or impetigo, which is caused by strep, and infected scabies as well, is really rife in these communities. And what I didn't mention in relation to that journey of the kids through the room is that we also do a skin check on every child.
Okay, yeah.
And we're finding extremely high rates of skin infection.
Skin infections.
In terms of children that we've found with abnormal scans, we have seen in total across those visits that I described earlier, 2,700 children.
Wow.
And we are finding consistently of the order of 5% of those children have rheumatic changes of their heart valves. And we have found over 80 children with definite and previously undiagnosed rheumatic heart disease.
So, Gavin, that's quite an astounding number. And I think it's really important for our listeners to understand. So, as I said in the introduction, you're a paediatric cardiologist at the Women's and Children's Hospital here in Adelaide. You're doing this work voluntary. You also have another role that you play, and that is you've been a part of the executive team of the Women's and Children's Hospital for, are we going to put a time on it? Is it a decade or is it a couple of decades, Gavin?
Yeah, no, I have worked at that level for a long time. For
a considerable amount of time. And the reason I'm wanting to really touch on that is this really important work that you're doing is all voluntary. And it's voluntary cardiologists, and you've just mentioned sonographers. Obviously, you're relying on other medical practitioners locally in some form. You're relying on that welcome from those Aboriginal communities to come in. Obviously, that buy-in from the teachers and that education piece. So why is it that we have yourself, all these other volunteers, and Dr Bo coming up with the seed of the idea, to use your term, 2 years ago to take this trek? Why is this taking a group of specialists and healthcare workers voluntary hours to actually help bridge a gap and even start the inroads to eradication. Yet, like we discussed earlier, we're a privileged country.
So the people involved with the Deadly Heart Trek are extremely passionate, and many of us have worked for decades in this area. And I should emphasise that the team is much more than cardiologists and sonographers.
Of course.
We have wonderful Aboriginal leadership and cultural guidance. We have a number of, other doctors, nurses, coordinators who have been really crucial to the program as well. So a great group of very passionate people with support, as you know, I think, Sami, from the Snow Foundation, with some charity funding as well. So there's an enormous amount of passion. There is great frustration and alarm, actually, that this disease is not going away and is in many ways worse than it was historically.
So, Gavin, are there any short-term outcomes that we can address besides, obviously, the education and hygiene? Is there other, for the want of a better word, some short wins that we can get on the ground sooner from these insights that you're bringing back from these treks?
I think it's the nature of this problem and this disease that there aren't a lot of quick wins. There aren't a lot of quick wins. I think it really is the longer game that is so important here. In terms of the work that we're doing, and this is a small fraction of what needs to occur, and I think it's important to say that. But in terms of the work that we're doing, I think that I certainly believe that it needs now to transition to a proper program and regular screening, probably 2 yearly in high-risk communities. That is a very big undertaking and requires the resources, obviously, to do it. It needs the people, the expertise, the equipment, and a program built around that.
So what I'm really hearing, Gavin, is the work that the Deadly Heart Track is doing is just scratching the surface.
Yes, I think it is.
It's that funding for this to roll out into, let's just call it, we're not obviously getting political, but a national program, a funded national program, so that this disease, from everything I'm learning tonight, it's preventative, is it not?
Well, prevention is where we need to be. And so prevention occurs at a number of levels, doesn't it? If you start at the very pointy end, there's tertiary care.
Yes.
And so that requires medical follow-up, hospitalisations, cardiac surgery. That's not really prevention.
No.
Right. So if you come back upstream a little bit, you get to secondary prevention. So you make a diagnosis and prevent recurrences of rheumatic fever by giving regular penicillin for many years.
Okay.
And one thing we didn't touch on earlier is that people that get rheumatic fever once can get it again and again and again.
Okay.
So they're very prone to getting recurrent episodes of rheumatic fever with streptococcal infections. And that's actually a key part of this disease.
Okay, so if I'm infected once, I've got a greater chance of being reinfected?
So you've got a very much greater chance of getting rheumatic fever again if you get a future streptococcal infection.
Okay.
And we know that the people who get the most severe rheumatic heart disease will usually have had repeated episodes of rheumatic fever.
Okay.
And that's why we think that it's possible, and there is evidence now that it's possible to make an early diagnosis, treat with penicillin, prevent those future episodes of those recurrent episodes of rheumatic fever, and end up with good heart valves. So that's the purpose really in what we're doing with screening.
Yeah, absolutely.
So that's secondary prevention. If you come a further step upstream, you get to primary prevention, which is essentially diagnosing and treating sore throat and skin infection. That's not been terribly successful as a strategy, but I do think that we need to do better at primary prevention.
And do you think that primary prevention also includes education?
Well, you probably have to come a step further up that upstream, right? Yep. And that's where you get to primordial prevention. And that is about addressing the social and economic determinants. And that's really, I think, where we need to be.
Yeah. And incredibly, like I've touched on earlier, incredibly frustrating, because that's like everything when you step it, like you've just said with the analogy, keep going upstream. It almost gets wrapped up in the toot hard basket, doesn't it?
Oh, well, it shouldn't.
No, it shouldn't. But it's unfortunately some of these things that we see, because like you've said, there's plenty of literature out there. We know that you can go in and you can diagnose within, like you said, 2 minutes. So we've come that far with the medical technology and with your profession, and then you throw in some dedication and passion, that's what leads to a 2-minute diagnosis. So it's something that we really need to address, isn't it, Gavin? And I'm sure something that you're obviously incredibly very passionate about. So what are the next steps, if we can lighten it a little now? Because I think what we've talked about is incredibly alarming. It's shocking. I feel embarrassed. I feel embarrassed that this is going on in our country. But if we to take it of what are the next steps for the Deadly Heart Track, what's the goal that you have and Bo and the team of volunteers? What's your next goal?
Well, I think we have an important responsibility to advocate with government, an important responsibility to inform and educate. I think that too few people in this country have much awareness, and I think that's very disappointing. So consider, if you will, Sami, that it was found in a suburban primary school in Adelaide or Melbourne.
The North Shore in Sydney.
Or the North Shore. That 5% of children had damaged heart valves from a disease that is entirely preventable. What do you think the response would be?
Huge outcry. Huge outcry. I can't even begin. I don't think you would be flooding your social media. It'd be flooding the radio. It would be flooding every television network, would it not?
Well, I think it would, and it's, the sort of thing that'd be very damaging to a government or two.
Mm.
And yet this is happening as we speak around the country, and particularly in remote communities. So I think we have a responsibility to inform, educate, alert people to this problem, and then to do something about it. I think the other comment I would make is that people may look at rheumatic heart disease, rheumatic fever, and say, well, that's one disease. There's all these other problems, chronic renal problems, diabetes, etc. And I would acknowledge that, but this disease is different. It's like a flagship for disadvantage.
Mm.
And we know that if you address those determinants of health, not only will this disease go away, we know it will go away, but so many other things will be better as well. So there's an absolute imperative, I believe, to address these things. And right now, we're not managing that. And I say we collectively.
Yes.
And so I think it is important that we lift this up as an issue. Dare I say it, give voice to it.
Absolutely. So to wrap up what you've just said is it's about advocating, and I think that's what we're doing here tonight with this podcast. This is national. We've got a very big, passionate, beautiful, driven HeartKids community. And I think anyone listening in tonight has learnt a lot. The piece around advocacy and sharing that information and that education. I know that you actually got some videographers involved and you filmed your last trek. So is there something that we can do there as a community, Gavin, with screenings of that video? I've been very privileged to see it. I watched it here at Parliament House along with yourself and many other important people who have voices and have the ability to advocate. Is there something that the community can do?
Well, I think there have been 2 films made, and fabulous work, I must say, by the Moonshine Agency. The first film, I think, was from around 2016 and was called Take Heart, and the second film was called Take Heart, Deadly Heart. That was the film we saw together recently, Sami, that you mentioned. I think they do an excellent job, actually, of capturing the real story here. And, the real story in the end is about kids, young people, families, and the terrible damage that this wreaks on them.
And we haven't actually put a number on it, Gavin, but What is the prime age that we're seeing this rheumatic heart fever and disease and then the decline of the mitral and aortic valves? What's the age in which we're seeing this primarily?
So the peak incidence for the first episode of rheumatic fever is between 5 and 15 years of age. But it's certainly possible to get a first episode as an adult, and we see children as young as 2
Wow.
with rheumatic fever and sometimes with very significant valve damage even at that young age.
Gosh, that's incredibly hard to get your head around, especially too when we know that this is all preventative. So Gavin, everything that we've just been talking about, do we know what to do next?
We do actually. So there's been some very good work done through a Centre of Research Excellence led by Jonathan Karapetis at the Telethon Institute in Perth that has led to a roadmap or development of a roadmap for RHD and the concept of elimination of this disease by 2030.
Wow.
And that report has identified a number of key priority areas for the elimination of the disease.
Okay, so we can really tie it into that stream. So I suppose if I can wrap up by thanking you from my heart and from the entire HeartKids community heart, but I think also too, as more people hear about this, a heartfelt thank you to yourself, Bo, all the volunteers. As I said, I'm not just hanging this on yourself, or you've said clearly there's a lot of people involved in this. We thank you for the tireless work and I'm sure the continued dedication. But if I can leave people with tonight that we all have the ability to advocate, every single one of us. We all have a voice. We can share this podcast. We can inform the greater community. And from that, obviously, that leads to education about what is RHD, how it affects our remote communities of Australians. And I think we all can participate. And if it means getting involved with your local council, community group, whatever it is, this is completely voluntary, the work that you do. This is not a part of your paid role, which is a very, very big role that you do day to day. We probably haven't even touched on that, but I think we do have the ability to share this podcast far and wide and reach out to the guys at HeartKids to see if you can get a hold of the documentary and you can see the work that Bo, Gavin, and again, huge team of volunteers that they're doing. And like you mentioned earlier, Gavin, it's only funded by a little bit of money from the Snow Foundation. Is that correct? So get in contact whichever way you can. This needs to stop. So Gavin, thank you so very much for your time and really appreciate your sharing your trek.
Thanks, Sami. Very pleased to be here and thanks for the opportunity.
Sometimes this podcast talks about some heavy things. If this brings up anything for you or someone you love, it is important to reach out for support. The HeartKids helpline provides support and guidance for anyone impacted by CHD. You can call the helpline on 1800 432 785. To access more information about CHD, as well as support from HeartKids, visit the website at heartkids.org.au. The information on this podcast is not a substitute for medical advice from your doctor or healthcare team. Always talk to your doctor about matters that affect you or your family's health.